Good evening. On behalf of Baptist Health, I would like to welcome you all to the second session of our three-part health series on LGBT health issues. Today's presentation is entitled Depression, Substance Use, and Suicide. I'm Glenwood Charles, Community Partnership Coordinator for Baptist Health. And before we begin, I'd like to cover some Zoom housekeeping. This session is being recorded. And throughout the session, if you'd like to submit a question, please use the Q&A feature in the red box at the bottom of your screen. If you'd like to chat with the panelists and the rest of the audience, please use the chat feature and ensure that you're sending your commentary to the panelists and attendees, as you can see in the blue circle. I'd like to introduce our moderator for this evening. Brian May is a local resident of Jacksonville, born and raised on the west side of town. As an educator at Baptist MD Anderson Cancer Center, he supports new employees coming into the revenue cycle with onboarding and training. When he's not in the classroom, Brian serves as the co-chair of Baptist Pride Employee Resource Group, which aids efforts to provide a safe, inclusive, and equitable environment for LGBT+ patients, families, team members, and the community. Ladies and gentlemen, Brian May. Brian, you're muted.
Thank you, Glenn, for the introduction, Glenwood. It is my honor to serve as your moderator for the evening and be given the opportunity to share important information with the community and our team members here at Baptist Health. Thank you to our panelists for volunteering your time this evening to share information, resources, and life experiences as they relate to today's topics. As a member of the LGBT+ community, the topics of today's session are super important to me, as I have experienced a few of these myself and understand how destructive they can be if not addressed. Eliminating health disparities and enhancing efforts to improve health are necessary to ensure that LGBT+ individuals can lead long, healthy lives. There are many benefits to addressing health concerns and reducing disparities, such as reduction in depression, substance abuse, and suicide rates. Studies show that LGBT+ individuals have a higher prevalence of these mental health illnesses when compared to the general population. Discrimination and marginalization are also some of these factors affecting these rates, but more can be done to confront this. So again, thank you for joining, and I look forward to today's webinar. So our presentation this evening will be separated into 4 parts: depression, substance abuse, substance use, suicide, and lived experience. Our panelists are all excited to speak with you today regarding mental health and mental well-being in the LGBT+ community. To begin, Shannon Silvestri will cover depression. She is a licensed mental health counselor working on Wolfson Children's Hospital's Behavioral Health Inpatient Unit, and she also provides outpatient therapy services to the Nassau County community. She received a Bachelor of Arts in Psychology and a Master of Arts in Professional Counseling, both from Lindenwood University. Shannon's passion is to help individuals and families work through life transitions and overcome crises. She enjoys snow skiing, attending sporting events, and all things that involve the beach with her family. Thank you, Shannon.
Thank you, Brian. Hello, everyone. I will be first starting with depression. So first, depression is the most common mental health condition in the United States, and it affects an estimated 17.3 million adults and 3.2 million adolescents in the United States, according to the National Institute of Mental Health. So depression affects the LGBTQ plus community higher than straight or cisgender folks. So I wanted to start with kind of the basics of depression. So let's define what are some of the symptoms of depression. What would a depressive episode look like? So first, sad mood, loss of interest or pleasure, significant weight change, diminished concentration, sleep difficulties, fatigue nearly every day, feelings of worthlessness, recurring thoughts of death, and these symptoms must be significant where it's causing distress, or they must last for at least 2 weeks in time. So some factors that put someone at higher risk for suicide include having a family history of depression or similar disorders such as mood disorders, poverty, unemployment, social isolation, other stressful life events like coming out to your family, what your true identity is. There are symptoms, these symptoms result in a decrease in their ability to function at work, home, or relationships. So next, I want to talk about briefly treatment. What do we do to help someone with depression? So we use psychotherapy and medication together. That's the best form of treatment. So for psychotherapy, we use cognitive behavior therapy primarily. That works by changing self-defeating thoughts and behaviors. And then for medication, we usually look at SSRIs to increase the level of serotonin in the brain, which is the chemical related to depression. Something that I think is really important to discuss when people are depressed, they tend to use negative coping skills. And negative coping skills may include self-injurious behaviors, substance use, risk-taking behaviors, overeating or undereating. So we really try to emphasize with our clients and patients what are positive coping skills. And I always make sure to talk about the 4 different categories. So there's calming and distraction, physical, and processing. So some examples of calming coping skills could be deep breathing, yoga, take a mindful walk, imagine your favorite place, and grounding techniques, all things you can practice with a therapist. Distraction coping skills may include writing a story, bake or cooking, doing a random act of kindness, read a book, clean, play with your pet, board games, and distraction by screen, which I think we all utilize in our lives, even though we don't want to admit it. And then physical coping skills, squeeze something, use a stress ball, for example, shred paper, use bubble wrap, shuffle cards, use a fidget. Fidgets are everywhere now, you can get them anywhere, and of course, exercise. And lastly, processing coping skills, understanding your triggers, tracking your stress, writing in a journal, writing songs, poetry, music, and talking to someone you trust. So how do we support someone with depression? That's a question we get a lot in this field. I think the most important thing is to first recognize depression as an illness because there is a stigma around it. Make a point to reach out to those friends and loved ones that we know may be struggling or may be exhibiting some of these symptoms mentioned earlier. Just listening can help, just letting them vent. Be supportive of healthy habits. So even if it's going by, let's go for a quick walk together. That's a healthy coping skill that we can encourage. Encourage professional help by making it more normal, normalizing it. Maybe if you've experienced going to therapy and sharing that experience. Connect your loved one or friend with social support. We have many, many social support groups in the area. So if you know of one that you think would be a good fit, share that. And take any mention of suicide seriously. Make time for self-care for yourself and that person. And ultimately, you're not responsible for curing your loved one or friend. Next, a common question that I've received since the pandemic has started: how has the pandemic affected the rates of depression, especially in general and in the LGBTQ+ community? So first, for Wolfson Children's Hospital, our inpatient behavioral health unit, we have seen an increase of admissions of 300%. So of people coming to the emergency room, and this was related to mental health when they're coming to the emergency room. And this is them comparing to the same time last year. And then when we go to looking at a survey that the Morning Consult and the Trevor Project did together, the poll surveyed 1,200 people across the US between the ages of 13 and 24 in late July of last year. And so half of them, 600, identified as part of the LGBTQ+ community, and the other half did not. So stay-at-home orders have led a lot to be stuck inside at home, as they're not allowed to go out in the community because of the pandemic. where they've been in unsupportive households, which led to adverse mental health effects and limited their opportunities to get needed care, according to the survey. So they weren't able to go to an outpatient office to get therapy or talk to someone at the school because everybody was online. Next, nearly 1 in 4 of the LGBTQ plus youth who responded said they were unable to get healthcare, period. So then we go to 3/4 of those respondents said they were suffering from increased loneliness since the pandemic began. So 55 specifically said they were having symptoms of anxiety, and then 53% reported symptoms of depression. And this was when they did the survey, they asked like in the past 2 weeks. So a significant amount. So the CEO and the executive director of the Trevor Project released a statement sharing that their crisis line and services that they have had doubled from before the pandemic because people were having such a difficult time. And so I think it's really important that we keep these things in mind, and we have seen that we're trying to become more creative by offering Zoom virtual appointments to help spread the awareness and support that kids weren't previously getting in school, or even our adults when they weren't going to work, to be even with their peers. So thank you, Brian. That's kind of my quick rundown of depression.
Well, thank you, Shannon. I appreciated the coping skills that you shared. As I mentioned in my intro, as a member of the LGBT community, I do suffer with a few of these, depression being one of them. So to provide those coping skills for us and the other attendees, I appreciate that. And also for bringing us some data and statistics to highlight the prevalence of depression in the LGBT plus community and the disparities that we face when we do seek help for depression. So thank you. Next, Maggie Mahaney will cover substance use. Maggie's currently a registered mental health counselor, counseling intern working on Wolfson's Children's Hospital Behavioral Health Inpatient Unit. She completed her Master of Science in Professional Counseling with an emphasis in trauma at Grand Canyon University, and studied psychology and criminal justice at the University of North Florida. Maggie has experience working in community mental health, as well as neuropsychological and psychological testing for both pediatrics and adults. She enjoys traveling and spending quality time with her boyfriend, friends, and family. Welcome, Maggie.
Thank you. So let's kind of dial it back to the basics. So I'm talking about substance abuse and substance use. So looking at the Diagnostic and Statistical Manual of Mental Health Disorders, 5th edition, we're looking at substance-related and addictive disorders. So this category encompasses 10 separate classes of substances: alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, stimulants, tobacco, and other substances. So all these drugs, when used in excess, can then activate the brain's reward system that reinforces behaviors and potentially can activate the brain in such a way that we consider normal activities can be pushed aside and then later neglected. So according to the DSM, individuals with lower levels of self-control, which may reflect impairments of brain inhibitory mechanisms, can be predisposed to develop substance abuse disorders. So typically individuals within the 18 to 24 age range typically have the highest prevalence rates for the use of substances. And we typically see intoxication and substances being used between the beginning of the teenage years. So the LGBTQ plus community is actually at greater risk for substance use and mental health issues than the heterosexual population. Biggest question is why? So we clearly can't pinpoint one reason or one contributing factor to why substance abuse is so prevalent in the LGBTQ community, but some of the common shared factors from previous clients and patients and resources kind of all revolve around social stigmas, social reactions, coming to terms with their own sexuality, and just overall discrimination. So even though there's acceptance, there can still be individuals in their lives that are discriminatory, homophobic, and these people can be friends, family members, coworkers, or complete strangers. So there's sometimes also a lack of support. So individuals may not come out publicly due to wanting to avoid harassment, which can lead to feelings of living a double life or not being honest, which can lead to symptoms of anxiety, depression, loneliness. And this is why individuals are using substances to kind of dull their emotional and mental pains. So sometimes there can be internalized thoughts of homophobia, self-hatred, self-loathing, being uncomfortable in your own skin. So individuals suffering from these thoughts will sometimes use substances to kind of quiet that negative self-talk. And when intoxicated, sometimes they feel like they can be their true self and not really have that barrier. So many individuals who identify as LGBTQ+ have co-occurring mental disorders as well that can lead to substance use problems or can perpetuate use. So some substance use individuals can be prone to mood disorders, depression, stress, anxiety, eating disorders, and other medical illnesses like hepatitis, HIV, AIDS, and STIs. So sometimes dealing with these medical issues can also affect the ability to participate and seek substance abuse treatment. So lastly, sometimes individuals need specialized treatment, but I'll talk about that in a little bit. In 2015, the National Survey on Drug Use and Health separated individuals who participated into two different categories. They separated it into the sexual minority, which individuals who identified as lesbian, gay, or bisexual, and then the sexual majority who identified themselves as straight or heterosexual. In this particular survey, they added questions to ask individual participants 2 questions in regards to sexual orientation, 1 question about sexual identity, and 1 question about sexual attraction. So this is a first national representation of collected information on substance use and mental health issues among the LGBTQ+ demographic. And according to that survey, in almost every substance category, the sexual minority almost reported double the usage than the sexual majority. So for example, that's 30.7% using marijuana in the past year compared to 12.9% of the sexual majority. So that's 5.1% of sexual minorities reporting use of cocaine compared to 1.8% of the majority. 2.3% of sexual minorities reported the use of methamphetamines compared to 0.6% of the sexual majority. And then 0.9% of sexual minorities reported use of heroin compared to 0.3% of sexual majority. So again, these results show the sexual minority as reporting almost twice as much usage as the sexual majority from the 2015 National Survey on Drug Use and Health. So lastly, kind of when talking and discussing treatment options, it's really important to remember that treatment is not one size fits all. So treatment options usually include motivational interviewing, social support therapy, contingency management, cognitive behavioral therapy, dialectical behavioral therapy, family therapy and education, and client-centered therapy. Addiction and substance use treatment programs offering specialized groups show way better outcomes for clients compared to non-specialized programs. Current research suggests that treatment should address factors like homophobia, transphobia, family issues, violence, and social isolation within the treatment facilities. The issue is that only 7.4% of programs offer specialized services for the LGBTQ+ community. For more additional resources, if you're looking for substance use, one of the best websites is to kind of look at the Substance and Mental Health Services Administration website or American Addiction Centers, because they can go into specific detail about the LGBTQ+ programs.
Awesome. Thank you, Maggie, for your information. You also provided a lot of data to support what we kind of already know with the LGBT community. Something that stood out to me was when you read off the statistics comparing the minority sexuality to majority, some of those statistics were double or triple in comparison to each other. So that just highlights the prevalence of substance use and abuse when it comes to LGBT+ communities and individuals. So I look forward to speaking with you later and asking some more in-depth questions. Next, our next panelist that I'd like to introduce is Justin Bowlingmo. He will now present on suicide. He is a licensed marriage and family therapist at Bapton Children's Center and provides therapy services at Jasmine. He completed the counselor education program and earned a master's of education from the University of Florida in 2014. He has previous experience working in Baptist inpatient, crisis stabilization, couples therapy, as well as individual therapy for pediatric and adult population. Justin enjoys working with LGBTQ+ clients and family systems, spending time with his husband and pets, as well as traveling, running, and reading. Justin?
Awesome. Thank you, Brian. Appreciate it. All right. So today I'm going to be talking about suicide. So suicide is one of those topics that's often considered really taboo. It's something that people are often uncomfortable talking about. I believe it's important to speak openly about suicide for multiple reasons. First and foremost, talking about suicide is going to decrease its stigma. You heard Shannon mention earlier about that mental health stigma that's out there. I would say that it's definitely improving over the years, but a stigma associated with suicide is still pretty prevalent. You'll often hear people who are skirting around the topic. Maybe they know somebody who passed away or did end up dying by suicide, but it's something that's very hush hush. We shouldn't talk about it ever, which I think is actually detrimental to improving the rates that suicide occur, or decreasing the rates at which suicide occur. In 2020, the US population reported an average of 14.8 completed suicides per 100,000 individuals, according to the American Health Ranking Annual Report. And you can compare that to the 2019 statistic, which was 13.93 completed suicides per 100,000 individuals. So you got to imagine the population of the country, and that amount of suicides occurring per 100,000, that's quite a lot of individuals who are taking their own life. Looking back 21 years to the year 2000, I know it's been a long time, the rates were 10.4 deaths per 100,000. So we're seeing a slow but steady increase in suicides, and that could be multiple reasons. Maybe there is more awareness and more people are talking about it, so we're getting more accurate measures. But we want to definitely ensure that we're preventing suicides as much as possible. It's one of those things that it's a lot of work to combat it. And some strategies that I recommend is using person-first language to separate the diagnosis from the person. An example of that might be, instead of saying that they committed suicide, you could say that they died by suicide. You may have heard me mention it in that way earlier. This is highlighting the disease as opposed to the individual. A lot of times we pair them together, and they're actually it's actually something that the person is experiencing, just like they might experience, say, diabetes or high blood pressure. They can experience suicidal thoughts. So it's a symptom, just like a medical diagnosis may be. Secondly, talking about suicide helps people feel heard. Imagine being in a dark place that you feel your only option is to take your own life to get some type of relief. Being unable to talk about that with anyone is so incredibly isolating, which further increases the risk of actually acting on those thoughts. Being able to speak about feeling suicidal and having those thoughts is key to prevention. I can't begin to help someone overcome their suicidal thoughts until I have an understanding of what led them to feel suicide as their only or best option. Now, some things that people may have asked in the past, or that I have been asked in the past, is, well, what do I do if I think someone may be having suicidal thoughts? I don't know what to say. I don't want to make it worse. So one of the best things you can do is provide that support and ask the person. Again, it's that taboo nature of suicide. I can't talk about it, but talking about it, like I said, is key. You can ask somebody. An example might be that, hey, Cindy, I'm worried about you. I noticed you don't seem like yourself. Are you struggling with any suicidal thoughts? Being upfront, frank about it is going to let that person know it's okay for me to be honest and tell them how I'm really feeling. struggling. That gets the conversation going, which then can lead you to say, well, let's get some help for you. Let me see what I can do. Do we need to go to the hospital? Do we need to go to Baptist? Finding out ways to provide that support, as opposed to, well, I didn't ask because I wasn't sure. And, we don't want, I didn't know what might happen if I asked. There's a misconception that asking people or talking about suicide will further lead them to being suicidal, as if it's like implanting the idea in the person's head. Suicide is something that everyone's aware of. Maybe not children, but that adults are aware of. So it's not going to be something like, wow, I never thought of that before. It's going to let that person know that this is something that's okay to share and okay to talk about and seek help. So yeah, thank you guys. Brian, I'm going to turn it back to you. I have some statistics we can jump into later, but I'm sure those will come up in the question and answer section.
Okay, cool. Thank you, Justin, for sharing that. As you opened up, suicide is very taboo, and it does have a stigma surrounding it. It's not often that conversations are created around it to discuss it, the signs, how to overcome it. So I appreciate you sharing that, and I look forward to speaking with you more later. I did see a question in the QA box from Laura Mitchell. Laura says she serves on advisory councils for both substance use and suicide prevention. She asked if she can have access to the recording and permission to share this with the members of these committees. Absolutely, Laura. This meeting is recorded, and you do have permission to share it. So next, and the last panelist that I'd like to introduce is Nan Hooker. Nan Hooker will present on her own experiences with depression, substance use, and suicide. She is a lifelong resident of Jacksonville and has worked at Baptist Health since 1996. She is passionate about finding solutions for social justice issues and feels strongly about working to eliminate the stigma associated with seeking mental health services. Nan enjoys spending time with her wife, Sue, playing both golf and tennis, and hanging out with their 4 sweet cats and dog, Lily. Nan appreciates the opportunity to share some of her story this evening. Welcome, Nan.
Thank you, Brian. I really appreciate being asked to come and speak tonight and to share some of my story. When my mother committed suicide, I had just turned 11 years old. That was in December. It was 3 days after Christmas. And that event became obviously a pivotal point in my life. One of the things it did, it made me 10 times more likely to attempt suicide myself in my lifetime. And the other thing I think it did was it sort of put me on a path of doubting myself, struggling with my self-esteem, feeling like I didn't fit in. I think I probably was a fairly shy child from the get-go, but that loss, that feeling of, in some ways, wondering as a child if I had contributed to her demise, as I think children sometimes do, it brought up all those feelings of insecurity, which I carried with me through the end of elementary school and into high school. I managed to do okay. I had a very loving and supportive father. I had a sister 3 years older than myself. But what really changed for me was in high school. When I was 16, I discovered alcohol. And alcohol became the solution to all my problems. I wasn't as shy when I drank. I wasn't as socially awkward or fearful. So alcohol became a longtime friend of mine for a good many years, and influenced so many of my decisions. The other thing that happened in high school for me was, and now you got to, these panelists are a little bit younger than I am. So when I was in high school, we're talking about the late 60s. I know I'm aging myself here, but that's okay. But, you know, I began to realize that as what few buddies I had, girlfriend buddies, they liked boys, and I did not. I didn't not like boys. In fact, I was quite a tomboy, and I enjoyed hanging out with boys, but I was beginning, as I was growing up and in that later adolescent period, I was beginning to understand that I thought I might like girls for a more important reason. And back then, that was not something I was able to say, oh gosh, I think I'm a lesbian and I'm really okay with that. It was just like an inkling of something that was part of my life at that point. So I made it through high school, just barely. And then I had a great idea to go and live in Birmingham, Alabama with my stepsister, who was 10 years older than me and whom I had known closely for just very short period of time. My dad had remarried when I was 16. And it was in Birmingham that I think my depression became stronger and deeper. I was drinking. I had gotten myself a job as a counter girl at Captain D's, and that was how I had chosen to make my way through life. And so I had a small apartment, a job, and when I wasn't being a counter girl at Captain D's, I was drinking. And so my life became extremely small and tiny. And along with that came depression and isolation. And even though I had my sister with me, she had her family and all of her life activities. And it was then that I tried to kill myself in a not very efficient way. I used a rusty knife to cut my wrist one night. And obviously I'm here, and that wasn't a sincere suicide attempt, but it was a sincere sort of asking for help. And I ended up going back to Jacksonville some months after that. And I got a job at University Hospital, which is now Shands UF. And I worked there in the Child Services and Behavioral Health. And I was a secretary there. And one day, because I continued to drink like an alcoholic, which meant daily, nightly, not so much daily at that point, but every night, Dr. Ernest Miller, who was the psychiatrist at that facility and director of psychiatry, he called me in and he said, Nan, you can't drink and you can't work here. You have to make a choice. And that for me at that time, as a sincere alcoholic, was a very hard choice. But I somehow managed to say, okay, you can send me to treatment, which they did. And so I went to Avon Park, Florida for treatment for 28 days. And somehow that worked on me. I went there thinking I wasn't going to quit drinking, that I would just do what they said and I'd try to keep my job. And it turned out to be the best thing that ever happened to me. And because I was able to quit drinking, I didn't fully get into 12-step recovery at that time, but I was able to not drink, and therefore I was able to become clearer. Therefore, I was able to go to school. I was able to kind of begin to undo some of the things that I had always felt about myself. I began to have a few successes. A little bit of schooling led to more schooling, and that fed into my feeling of success for myself. I met some people. I was able to reach out. And the other thing that I did that was so important was I went from treatment right into therapy. And I stayed in therapy for a number of years. And that was more than valuable. I mean, that helped me so much to learn how to process what I was feeling and what I had gone through, and enabled me to go back and deal some with my mother and the grief for that. So I'm probably running out of time, but the next thing, I guess, that was really significant for me, I had a couple of relationships with women, and one long-term relationship for about 11 years that was not very healthy. And I think in part that was because my partner was an addict, and I was a newly recovering person trying to deal with that. That was pretty difficult. And when I came to Baptist, as Brian said, in 1996, that's when I met my now wife, Sue, and she and I have been together for 22 years. And we have been married now for 4 years. Thank you for the Supreme Court, Barack Obama and Joe Biden. And it's just wonderful to be in a loving relationship. I think in relationship is where you learn more about yourself than anywhere else. And I've been very fortunate to be in this loving relationship. My family also loved and embraced Sue. And so I feel very, very fortunate that what started out as kind of a sort of a rough place, and through some very dark times, I was able to be supported enough to reach out for help and to get help and to find a path that's a lot healthier than it was back then. So thank you, Brian.
Absolutely. Thank you, Nan, for sharing that story. Words can express my appreciation for you doing that, sharing your life experiences with us. You know, that takes a lot of courage, and it's not easy in any way. I do want to extend my condolences to you regarding the passing of your mother. I can't even imagine. But I do hope that your shared experiences will be impactful for the other attendees, as it was for me. We do have a comment from Michael Valdez. He said, nice to have representation for us little older members of the LGBT plus community. Powerful story. Thank you for engaging with us, Michael. So now I'd like to ask some individual questions to the different panelists, then also have some questions that'll be open up to the floor. I would like to start with Maggie. Maggie, one of our attendees had a question for you in the chat regarding the survey that was conducted on substance use. Laura asked if transgender youth were included in that or not.
So unfortunately, that survey that was done in 2015 did not target trans due to the fact that they were asking pretty much solely about like sexual orientation. I know they had the question about identity and then the question about attraction, but they did not target trans in that specific survey. They kind of, again, just to define, they defined the sexual minority as individuals that are lesbian, gay, or bisexual, and the majority as just heterosexual or straight.
Okay, thank you for sharing that. Now, in your message, you talked about, you know, substance use and the prevalence. Something that stood out to me was when you mentioned that the age group, you know, that's kind of most at risk is that between 18 and 24. And I remember you mentioning marijuana as one of the drugs, you know, that they flock to. What would you say are 5 substances that are most frequently abused within the LGBTQ plus community aside from marijuana? What are they going to?
So like you said, obviously marijuana is one of them, tobacco, alcohol, amphetamines, and heroin. They're saying there was a report that said that gay and transgender individuals use tobacco up to 200% more than individuals that identify as heterosexual. In terms of alcohol, roughly 20 to 25% of the LGBTQ plus community report having a moderate to severe alcohol dependency issue. And then in terms of amphetamines, members of the LGBTQ plus community are 12.2 times more likely to use amphetamines.
Wow. Yikes. Those are alarming numbers. That's why I say yikes. That's alarming. Now, on the, say someone recognizes that they have an issue with substance use and abuse and they like to seek help. Speaking from experience, and, you know, as we all know, sometimes a person may not find a mental health counselor that's the right fit the first time around. So they kind of have to, you know, test everyone out. What attributes do you believe are important for a provider to have to treat a member of the LGBTQ plus community with substance issues?
That's actually a really good question. I think one of the main things that provider has to have is flexibility. Flexibility, providing a comprehensive approach for that individual person, being consistent and aware of if there are any cultural needs, just like you would as any other therapist, promoting self-respect, healthy behaviors, promoting healthy behaviors and educating healthy behaviors and being able to do so, supporting collective decision-making, reducing barriers to treatment and answering questions thoroughly for the client, providing obviously evidence-based treatment, and then creating a recovery community and just a safe space for that client. They have to, like you said, be comfortable.
Awesome. Those are great. I have a little sticky note open on my screen trying to take notes. But again, if for the attendees, if you weren't able to capture everything the first time around, again, today's session is recorded and that will be made available to you. So flexibility, cultural needs, we should look for someone who promotes self-respect. That's a big one. And education on healthy behaviors with a lot of others. Thank you, Maggie. And again, any of the panelists who have joined us this evening, if you have any questions for any of our panelists, please just put them in the Q&A box. I am in it right now, so I'll definitely, be sure to ask the team. Okay, thank you, Maggie. I will come back to you if anyone poses a question for you. Next, I'd like to go back to Shannon. She was our panelist who spoke on depression at the start of the meeting. The question, what is the link, is there a link, and if so, what is it, between depression and sexual orientation?
Yeah, that's a very common question I think a lot of parents have, especially with their younger children. But I looked at not only youth, but also adults as well. And they say that people who are part of the community are more likely to experience symptoms of depression due to oppression and discrimination, which happens in adults and youth, just in different areas. So these factors can arise obviously at school, home, and wider in the community. So as an adult, we can experience this in work as well. So I looked up some statistics about this, and half of LGBTQ plus students feel unsafe because of their sexual orientation. And that's at school. And we want our kids to feel safe at school, but half of them do not, because of how they express themselves. And a third of those students miss at least one day of school per month due to feeling unsafe. So then we end up avoiding these types of places. And then when you come to like our adults specifically, one survey said around 1 in 3 of those adults experience mental health conditions compared to 1 in 5 who do not identify as far as the community. Because the same thing, like when you go to work, there's that anxiety surrounded. Am I going to be judged, or am I going to get passed up for this promotion because of how I live my life and how I express myself? So yeah, there's definitely a link between those two.
Wow. Thank you for sharing. I have a follow-up question.
Yes.
So because of stigma and discrimination, LGBT youth are more likely than non-LGBT youth to struggle with depression. What are some things that we can do, or how can we help if we live in a community or a home where we are aware stigma and discrimination is occurring for that person?
So I think the big thing is finding your allies first, finding some kind of safe place. So for our youth, hopefully you have someone at school. Your school counselor is very well educated, and that's someone that you can go to and talk to. And then I'm sure we're going to attach this at the end, kind of our list of resources. We have quite a few resources and hotlines and even texting lines now. So you have someone to talk to when you're faced with living in a home that has people who don't support you, or you're having issues at school, or even if you're an adult at work and you're struggling to find people that you can depend on and lean on during these hard times. So I would say find your resources in your community, and thankfully we'll be linking some of those today to make it maybe a little bit easier for us to share with everyone in this area.
And then perhaps after you've gathered those resources, what would you suggest doing from there? Like in a tactful way, say, hey, I notice you're a bit different, or would you just, ask, hey, are you doing okay? You seem a little different. And just open the conversation from there. Hopefully, again, we're speaking about people in the community or in your household. So hopefully there's a rapport there to where they understand you're coming from a genuine place of concern.
Yeah, and it's kind of like Justin was saying earlier, kind of with suicide. It's, a lot of people try to avoid these conversations, but it's way better if we just come out with them and try to confront someone. So like if you see someone hasn't been themselves, checking in with them and be like, hey, it looks like you haven't been feeling your best. I hope you're doing okay. Is there anything I can do to help? To try to open some of those conversations, because some people are just waiting for someone to ask. And if you ask, a lot of people, you will hear it if they feel safe in that moment. So provide multiple opportunities for someone to share that information by consistently checking in on your people.
Awesome. That's a great answer. Thank you, Shannon, for your expertise on this topic. Justin, I have a few questions for you next, sir, leading into suicide. So Shannon mentioned hotlines that people can call that are available for different things if you need to speak to someone. Does Baptist Health have a hotline for the LGBT plus community to call if they are having issues or depression or suicidal ideations, suffering with substance abuse and need help? Do we have anything like that of the sort?
So we don't have a specific LGBTQ plus hotline, but we do have a 24/7 suicide hotline. So anyone can call, even minors can call this hotline. There's always somebody. They are housed at the downtown hospital, so that they're local. They can call. The number is going to be 904-202-7900. And again, that's 24/7. It's here at Baptist, and one of our crisis response counselors are going to be there to talk with you, regardless of what it is you need to talk about. So whether you're feeling suicidal or you're just looking to, you need to talk with someone, share a little more. Now, there are some exclusive LGBTQ plus hotlines out there. One of the most popular ones, probably most well-known one, would probably be the Trevor Lifeline. That is a LGBT hotline. So anyone who's feeling suicidal, you can call. I'll list the number there. We'll also be showing these at the end. But that number is 1-866-488-7386. And a newer hotline, it's been around, but it's not as known as the Trevor Lifeline project is. But the Trans Lifeline is a newer one. That's specifically for trans individuals or non-binary individuals who want to call in. I know that is often, it's difficult, even within the LGBT community, there's discrimination against trans individuals. So, I think it's great that there's a hotline specific for that population. That way they know that person is trained to, work best with them. And that number is going to be 877-565-8860.
Thank you, Justin. Wow, we have a lot of lines. Learned something new today. So you said that this is available for everybody. When you say everyone, that means you don't have to be a patient, you don't have to be an employee. This is available to the community, correct?
Correct. Yeah. Anyone can call in.
And is this a free service to the community? No health insurance, nothing, no payment needed. You don't have to have health insurance. This is a free service we provide to the community, correct?
Correct. Yep. 24/7. Anyone can call in. Even if you're 15, 16, you want to call 2 a.m., someone will be there to talk to you for free.
Awesome. It's good to know. So speaking on suicide, how do you think, based on data or what you've seen in your role, in the conversations you have with clients going through crises, how has the pandemic affected suicide rates? Do you see any changes there?
Oh, absolutely. Like Shannon was saying, here, even just locally at Wolfson, we had that 300% increase in children, minors, adolescents presenting for mental health crises in our Wolfson emergency room. It's not just impacting us in Jacksonville, it's impacting everyone. Some interesting statistics that I found is that 70% of LGBTQ youth stated that their mental health was poor most of the time during the COVID-19 pandemic. I know we're technically still in it, but as I think it's referring to as when we were really locked down. Nearly half of LGBTQ youth said that COVID-19 impacted their ability to express their sexual orientation. More than 80% of LGBTQ youth stated that COVID-19 made their living situation more stressful. So definitely seeing how not having that ability to be in the community really impacted their mental health. Another interesting one, nearly 60% of transgender and non-binary youth said that COVID-19 impacted their ability to express their gender identity. So that we can see that the pandemic, unfortunately, for a lot of LGBTQ youth who are in non-accepting homes, had to really withhold themselves and stifle their expression and who they are because they're in families who are not accepting and won't allow them to be the individual that they truly are.
Thank you, Justin. Thank you so much for those resources that you provided to us on suicide and the hotlines that we have available here at Baptist Health to serve the community. We are approaching that 6 o'clock cutoff, so I want to jump to you, Nan, and ask a few questions regarding your lived experience. What are 3 pieces of advice, or maybe 3 or less, to whatever you have available? What advice would you give to a young LGBT person who may be struggling with depression or suicide based on your experiences?
Well, thank you, Brian. You know, this conversation is making me think about how intergenerational this is. You know, while I gave a shout out a minute ago to how far our society has moved along, we've also got a lot of work to do and a lot of way to go and a lot of minds to change and a lot of stigma around people being gay and lesbian and trans and questioning. And so while we've made a lot of progress, we need to make more. And so what I would tell the youth, because we've heard these statistics, which are, they're seriously, you know, worrisome, that and understandable, but the reason people feel more depressed and more likely to harm themselves is they don't feel as supported, I believe, and they don't know where to find help, and they don't, in the general world we live in, feel that general support that they're okay. So I think a couple of the panelists so aptly said, finding support, where that is it in it's your school counselor, as Shannon said? Is it somebody you might know at your church that you can reach out to? Is it just somebody that you can share? I think one of the most important things that I learned is that if I can learn to share my story, and I can share that with somebody else and not keep secrets about myself, but just be who I am. While that can be kind of scary at first, the more you do it, what happens is people feed back to you that you're good and that you're okay. And as long as you're with allies, as long as you're sharing yourself with people that can be trusted, and hopefully most people can find those trusted people. So I would say that is like one of the most important things, is reaching out for help and learning to kind of be okay telling the truth about yourself.
Thank you. So from that, you say find a support system, reach out for help when you need it. And what was the last one you just said?
Be okay telling the truth about yourself.
Be okay with telling the truth about yourself. I do agree that that's a big.
I attended a workshop once long ago that was the entire theme, was learning to tell the truth about yourself, which meant whatever you are, however you are, whatever you think, whatever it is, just be that. And then again, you get feedback from other people, and that helps to reinforce that. They say sunlight is the best disinfectant. So if we're thinking about trying to heal, as we let the light in and let the light out, you know, I think that's real important. Something to think about.
Awesome. Well, thank you, Nan, for that advice. I hope that, again, the attendee who asks for permission to share, I hope that the people in your committee and that you speak to it within the community, I hope that they find that advice helpful and find ways to implement it. Last question, Nan, before we wrap up. I want to know, how has being a member of the LGBTQ plus community affected your spirituality, if at all? Because I know that you're married, you know, you go to church, you did mention church. So has that affected you either helpful, like positively, or negatively?
Well, that's interesting. I'm going to tell you a quick story, if I may. Some years ago, I attend San Jose Episcopal Church. The Episcopal Church is not a particularly conservative church, but then on the other hand, it's not particularly liberal. And some years ago, when the Gene Robinson, who was the bishop in New Hampshire, caused some conflict in our church about an openly gay bishop being able to practice. The local bishop here in Florida at the time, a different person that's there now, he had our priests read a policy doctrine from the pulpit, which was nothing but horrible, homophobic horribleness. And I sat there in the second pew where I'd sat in my childhood listening to this doctrine being read, and I left the church in tears. It was really, really awful. So the reason I say that, and the reason that I feel like that's probably the most I've ever been discriminated against, and it came in my adulthood, actually. What happened though was one of the church members that I knew called me and said, you know, I don't know about this thing about you being gay and all that. I'm not sure I really like that, but I really like you, Nan, and I hope you'll come back to church, because I had stayed away for 6 weeks or so, not sure if I would ever come back, quite frankly. And to just finish my story very, very quickly, when Sue and I got married in 2017, we had a reception a month or so after we got married. And we had like 75 people from our church. Our church is not that big. We had 75 people come and attend our reception in our backyard. And it just kind of goes to show that, you know, when you let yourself be known to people, people respond in a positive way, or at least that's been my experience.
So
Thank you for
I
asking
just want to
that.
confirm, the people that showed up to the reception, were they some people from the church? Like, did they come around? Is that what I'm
They
hearing?
were all we have maybe 4 liberals in our church, and the rest are not so liberal. I'm sorry, it just is kind of how it is. So they were all welcoming and all wonderful. And I will say one more little quick thing. And I know this isn't true for everyone that struggles with your spirituality and being gay, and is it okay, and does God like you still? I believe I have been so lucky and blessed, because I never once believed God didn't love me. And I encountered a lot of people who felt that they were being left behind by God and the church. And you know, the church can do a whole lot better job of helping people in our community. And our church it's moving to the left. It's great.
I love what you said, that you never felt that God didn't love you. I didn't realize that I also can agree with that. Despite the discrimination and, you know, hatred or whatever that I may have experienced from other people, not once did I ever felt that I was forsaken by God or left by God. So that's a good thing to call out. I appreciate you for saying that.
Thank you.
Unfortunately, to my panelists and to the attendees, that is all the time that we have today. But I do want to thank you for your engagement this evening in the chat, and just for taking the time out of your schedule to join with us to engage in this conversation. I would like to thank Shannon, Maggie, and Justin for presenting on such important topics, and you, Nan, as well, for sharing your story with us. Again, I hope that this will impact other people who view this recording as it did me and Michael this afternoon. It's been my pleasure to moderate you. This was my first time serving as a moderator for a panel discussion. I enjoyed it, and I look forward to joining for Series 3. I'll turn it over to Glenwood from here.
Thanks, Brian. We are running low on time, but if we can just give like a virtual thank you, virtual hand clap to all our panelists. Brian, again, thank you for moderating your first time. It was great just to watch you work. Maggie, Shannon, Justin, thank you all just for your time and expertise. And Nan, thank you just for, as you said, giving your truth and sharing it with all of us and allowing us to listen in on it. This has all been so great. Geraldine just chatted in, great panelists. Thank you for having this webinar. Yeah, so just want to wrap up really quickly so we don't go over 6 o'clock. So as Justin was saying, there are mental health resources available. So Baptist Health Suicide Hotline, Trevor Lifeline, and the Trans Lifeline. In addition to these, we will be sending out a mental health document that has local and other national resources. And we'll be sending that along with the webinar once it is digitized for you to easily disseminate with your committees, your communities, coworkers, etc. And as Brian said, we do have the 3rd and final session coming up on August 12th. That's entitled Disparities in Healthcare. Hopefully you'll be able to join us, and we'll send out a link to that as well, along with the other resources from this webinar. And just want to say thank you. And again, just at Baptist, we are committed to changing healthcare for good for a lifetime of health together. So on behalf of Baptist Health, thank you for participating in this webinar, and good night.